Hello friends, my name is Dr. Tarun Madan. I am working as an intervention cardiologist and angiologist in UNMICRC Institute, and I will be today talking about Dvt endovascular treatment. Deep vein thrombosis, as we know, is a thrombosis in the deep veins of legs or arms. And what is the mechanism? It is the age-old varicose triad which is responsible for deep vein thrombosis, in which there is endothelial injury, thrombosis, and then hypercoagulability and abnormal blood flow. This all combined leads to thrombosis. What are the risk factors for DVT? Age, sometimes senility, long distance travel, immobilization for a long time, past history of DVT, abnormal veins, malignancy, which is a procoagulant condition, post-surgical bed rest, and post-trauma bed rest. This is how a deep vein thrombosis looks like. The normal veins have valves which allow the forward flow of blood into the veins, and whenever there is a thrombosis, the veins dilate, and this thrombus can also dislodge in the form of embolus and goes to the systemic venous circulation, which is the right side of the heart, and a very life-threatening complication in the form of pulmonary embolism can happen. So, why it is important to treat the DVT? Because half of the patient will develop post-thrombotic syndrome, which is called PTS, and 1/5 of the patients will suffer recurrent venous thromboembolism, that is deep vein thrombosis or pulmonary embolism. Venous thromboembolism is a leading cause of preventable hospital death. It's the third most common cardiovascular disease in the world. What are the signs and symptoms? Signs and symptoms are classical swelling, increased temperature or warmth, pain or tenderness, and redness, or there is change in the skin color. This is how a chronic DVT or acute DVT would look like. The first picture shows eczematous changes in the left leg, and the second picture shows swollen left leg, which is very, very edematous, and the patient is not able to bend the knee. How do we diagnose? A simple test called color Doppler sonography venous, which is a duplex scan which will identify the varicose veins versus DVT versus lymphedema. And then we can go ahead, if the creatinine is normal, for CT venography to assess the central venous system, inferior vena cava, renal veins, and iliac veins. And or if the creatinine is impaired, we can go for MR venography. What are the consequences if we do not manage the DVT in time? There is late resolution of swelling, there is post-thrombotic syndrome, there is venous ulcer, there is chronic DVT with persistent leg venous hypertension, that is called CVI, and then pulmonary embolism, which is very dreadful. So there is a disease in which there is a thrombus formation, symptoms are there, observation, and then treatment goals. Treatment is prevention of pulmonary embolism, propagate the thrombus, you have to prevent that, recurrence of DVT you have to prevent, and post-thrombotic syndrome you have to prevent, and you have to maintain the valve competence so as to have avoidance of secondary varicosities. So to improve the quality of life, this is how a venous system in the leg looks like. External iliac vein, which is formed by common femoral vein and deep femoral vein. Deep femoral vein is joined by femoral vein and great saphenous vein, and this is in continuation of the popliteal vein, and then popliteal vein is formed by the posterior tibial veins and anterior tibial veins and peroneal veins. And whenever there is a post-thrombotic syndrome, you get ulcer in the medial aspect of the leg because of the dependent edema, the skin excoriates, and then it leads to the valvular damage. Residual thrombus propagates until the symptomaticity again, venous insufficiency, and then daily life of the patient is very much hampered. So 40 to 60% of proximal DVT would develop eventually post-thrombotic syndrome, and it is very, very important to prevent this permanent disability. What are the treatment options? Gold standard till date was anticoagulants. Either you give acetrom, acinoquamlon, warfarin, or the NOACs, which is apixaban, dabigatran, or rivaroxaban. Second is to put an inferior vena cava filter. Different filters are available. In India currently there are 3 filters available. One is from Lifetech, second is from Bard, third is from Cook. So the different filters are there. Sometimes these filters are permanent, sometimes they are temporary. But in my personal opinion, the filters should be removed as early as possible once your threat of embolism is gone and you have managed the DVT very nicely. Interventional treatment, you have CDT, catheter directed thrombolysis, or SOS. If there is an obstruction in the iliac veins, you can do stenting also. So this is how over last 30 years, starting from the 1950, the DVT therapy has evolved. Anticoagulant in the 1950s and systemic thrombolysis in 1980s. Then in 1990, the local catheter directed thrombolysis inside the thrombus, and then pharmacomechanical thrombolysis means aspiration. And now today we have a lot of devices which give rise to isolated pharmacomechanical thrombolysis. So we have ECOS catheter, we have angiojet machine, we have Tralis, which is a thrombectomy device. With thrombolysis, we have to look for baseline CBC, platelets, coagulation profile, watch for bleeding in the cavities, in the brain, in the thorax, in the peritoneal cavity, and from the orifices in the form of hematemesis, hemopsis, or hematuria, or the bleeding from per rectum, local site bleeding. So how is a catheter directed procedure or a mechanical thrombectomy procedure is carried out? This procedure is done in the cardiovascular cath lab, always in the prone position because you have to go antegrade perfusion of drugs. So popliteal vein is selected under the ultrasound guidance as I will show in the later part of the slides. Percutaneous 8 French sheath. Preference of the patient is there for general versus local anesthesia with sedation. So this is a typical position of DVT patient when he is lying in the OT, and this is popliteal vein which is selected under ultrasound guidance, and this is how a patient who received therapy for the left leg in the first picture and the right leg in the second picture. So these are pictures in the prone position. So the left leg comes on the change, means when the patient is lying down prone, the left will come to the right and the right will become left. So how the mechanical pharmaco-isolated thrombolysis is done? You isolate the thrombus between 2 balloons, give Lytic in between 2 balloons so the embolization doesn't happen, and you have to give less thrombolytic dose, and then you aspirate. So this is a Tralis thrombectomy device from Covidien. It has 4 ports and then proximal and distal balloon port. Inflation syringes are there, aspiration port is there, and the infusion port for the thrombectomy agent. Local delivery of thrombolytic agent is because of this machine. Smaller doses of thrombolytic is used, shorter duration of thrombolysis, and it can be used in patients with relative contraindication to thrombolysis. It's less costly. This is how the proximal part of the Tralis PI system looks like. Tralis peripheral infusion system, balloon inflation ports, infusion port and aspiration port, and this is isolation treatment zone. And then in between these 2 balloons there is an oscillating drive unit which can increase the frequency of the vibrations, and then it can agitate the thrombus, allow it to mix with the thrombolytic drug and let it dissolve. So the first principle is isolate. The proximal and distal thrombus isolation balloons, they will minimize the risk of bleeding complications. Dissolve. Circumferential pattern of infusion holes and consistent amplitude of dispersion wire because of the vibrations will enhance the Lytic distribution for better dissolution of acute thrombus. And the aspiration window is designed to remove the Lytic and dissolve thrombus along with. This is how it works. Thrombus is isolated and target delivery of thrombolytic drug is carried out, and single setting treatment is possible in 83% of the cases. So this is how a picture shows that the thrombus has been isolated by one proximal balloon and distal balloon, and the patient is lying down in the prone position, a popliteal venous puncture is carried out, and then a guide wire is passed through that. Once the guide wire goes along, over that guide wire the balloon catheter goes. This is a thrombus in the iliac vein, and then you isolate the thrombus by inflating a balloon proximally and one balloon distally. Once these balloons are inflated, you start infusing the drug from the central part, and then simultaneously the central part also vibrates depending on the amplitude and frequency set by the control. And this thrombus is agitated, mixed with the lytic, and over a period of time the thrombus gets lysed. Then the balloon is deflated, everything is aspirated, and then the patient is put on anticoagulants and sent home. This is pre-op. You see the sheath is there, and the superficial femoral vein is absolutely occluded. This is the thrombus which was aspirated. This is how the right-sided common femoral vein, the superficial femoral vein, everything is occluded. This is how the external iliac vein, common femoral vein, and common iliac vein, everything is occluded. And then once you do trellis, it is 100% clearance of the clot. Bed rest is given 4 to 6 hours, and then you wrap the limb with compression stockings, and anticoagulation is prescribed. This is how we do in our lab. A patient is lying down in the prone position very comfortably, and you see that there is a sheath insert in the popliteal vein, and the guide wire goes through, and then through the guide wire you put this infusion catheter, and then through the infusion catheter you infuse your thrombolytic drug. This is how we aspirate the clots. And in the second picture we can see the inferior vena cava, common iliac vein, and external iliac vein is totally occluded, and then the superficial femoral vein, after the thrombolytic therapy, it's absolutely clear of the thrombus, and a good patent flow is established. This patient shows a chronically occluded left iliac vein. In the second picture we can see the left common iliac vein is totally occluded, left external iliac vein is small, and there are multiple collaterals. So now after the balloon angioplasty, you see the first picture shows a beautiful recanalization, and then in the second picture it shows there is a stent placed in the common iliac vein, which has given rise to very good antegrade flow, and the limb swelling has resolved. So don't wait before it's too late. We have to act fast. 15 days is the window period, and CDT is the best option. So always lyse if there is no other contraindication. If there is a low platelet count, then without lysis, pharmaco, means only mechanical thrombectomy, is good enough to treat these patients. Thank you so much.